Good afternoon, everyone. I am Krista Rolando, and I am the administrator with Relivar Home Care and Alivity Care Advocates. And we help people who are struggling to remain independent in their home. We can help if you are struggling, if you're overwhelmed, and if you're just worried about what your future might hold. You can give us a call today and we can talk about how we can help. We can help with medications, personal care, any of those things that you may worry about. And today we're here with Misty Delegado, who is the CEO owner of Relivar Home Care and Alivity Care Advocates. Hi, Misty.
Hi, so excited to be here. This is going to be a good information.
Yeah, absolutely. We're glad you're here too. And we also have Caitlin Polhill, who is an occupational therapist. And hi, Caitlin.
Hi, I'm happy to be here as well.
Yeah, thank you for joining us. So today we are going to be talking about aging in the home safely. And that is why Caitlin is on this call. We do these calls, our community resource education, to let people know, about things they're wondering about. Maybe they don't hear about it so often. So we like to cram your brain with some information, and we feel like this is a really important one. Caitlin, do you want to explain who you are, how you got to be an occupational therapist? And kind of,
Yeah, thank you. My name is Caitlin Polhill. I was very passionate about hands-on care and holistic approaches, so OT grabbed me. I graduated from Eastern Michigan University in 2017 with my master's degree in occupational therapy. I also have a bachelor's degree in psychology, so I feel like those help me a lot with my interactions in patient care. And then I also do medical case management for survivors of auto accidents, so traumatic brain injuries, spinal cord injuries, the whole gambit. And I'm blessed to be able to support them. I do big home modifications for individuals, recommendations for safety in the home, and functional assessments. So it keeps me busy.
oh yeah, it sounds like it. Those are all very important jobs. So thank you for doing what you do.
Thank you.
Can
love
I
it.
ask you a quick question about that? Just the differences, because I think some people might not understand the difference between a home safety assessment versus a functional assessment. Is there a difference?
Yeah, they're absolutely, well, so they kind of go hand in hand, but so I do functional assessments, not to be confused with neuro psych exams. So that looks at the cognition of the brain and functioning of that. But I often go into the home and I assess people on their ADL capacities, so activities of daily living, um, basically toileting, dressing, the things like hands-on services. And then I also assess for IADLs, or instrumental activities of daily living, which are more complex things such as money management, grocery shopping, organization, those things. So then by interviewing and working with the client and seeing them in their environment, I can comment on the level of care that they need. And we base it on contact guard, standby assist, min assist, where home modifications, I do the same thing where I look at that person, but I am not assessed. It's kind of it's a marriage of the two. So I'm looking at the functional aspects, but then I'm also taking into consideration like caregivers that are provided. And then I'm looking at the environment to see how the environment can support that client. So I'm not necessarily making goals for them or things like that. I'm just trying to meet them where they're at and make them the safest they can be and the most independent in their environment as possible.
Okay, got it. And you're mostly doing this for people that have been in catastrophic auto accidents, correct?
Yeah,
Okay.
at this time I am, but back in 2017, I was one of those. I worked at a skilled nursing facility, and I was one of the OTs that really drove the train, because a lot of people don't know this, but if you're in a skilled nursing facility and upon discharge, you can request an OT or a PT to come to your home, and Medicare covers that. So I would always offer those services. A lot of OTs, don't like to do that, but they will. I could go from a skilled nursing facility with that client and a family member, go through their whole home, and then make simple recommendations or even large recommendations that the family would have to then modify, or the client would have to modify, or not, they don't have to, but it would give them an idea of how to make the individual safer when returning home to avoid a readmission.
I think that's the best kept secret nobody talks about.
Yes.
Yeah.
Yes.
Thank you for that.
Yes.
If you're listening to this call, you're gonna want to write that down, because
Yeah.
what happens for training and education in the facility is completely different when you get to the home, and what we actually see when they arrive, and there's 5 steps to get in that front door, and there's no railing, and so much between there and home.
Absolutely. Like in a nursing facility with the rehab, you're in a modified environment that's set up for the client to be successful. So it's a whole different ballgame when you get home. And a lot of people, that's where the disconnect happens.
Hey,
Yeah,
no,
definitely.
thank you for that.
Yeah, and I would say too, a lot of times family members or the patient themselves don't realize what they're missing in their home. They think they'll call us and say, hey, we're all set up. Let's go home and start care. And then you get there and you're like, whoa, we need some help here. Right.
Yeah.
So,
How do we even get this person into the car to drive home? Like that, I
yeah.
would also too, if we're talking about your rights and things to request, if you are rehabbing at a skilled nursing facility, you can absolutely request a therapist to have a family member bring a car in. And then I've done car transfers so many times with individuals. I just bring them out of the facility and then we try with the actual car that will be transporting them instead of doing, kind of a car transfer in the facility. It's very different. So very different safety aspects, planning, things like that. You want to set
Right.
yourself up for success.
Yeah.
Right.
Great.
And that family member then has to do it. How do you get them out of that car?
Yeah. And they cannot request that one-on-one training with that OT.
Got it.
Yeah.
Thank you.
It's very reasonable.
Yes.
Or PT. No, I'm not discriminating.
Thank you for telling us. So while we're talking about that, we want to talk about some of the safety concerns with seniors, and we know there are several of them. And I know with you, you're a wealth of knowledge, and we're going to touch on a few things today, and then maybe create a whole nother presentation for next time. But I know we're going to talk a little bit about falls and mobility issues, and then I know you wanted to touch on DME. So, do you want to talk a little bit about your recommendations for basic home safety?
Yeah, absolutely. So some basic home safety things that are easy to do and don't cost a lot are things like removing clutter. So a lot of people who are in the home and they're elderly, they have a lot of throw rugs, they have a lot of boxes, they have a lot of, the tables in the middle. And I'm not saying to go in and do an overhaul of a person's home, because what I was
They
telling
won't get that.
what's that? So, I mean, you can, but you want to also be respectful, of course. That's number one thing, is that this is not your life. This is this person's life. And I'm here to assist. I'm not here to demand. And so I typically would go in, I'll be like, these throw rugs are not so good on this floor. And then I will demonstrate with the walker or whatever durable medical equipment or DME that person has been recommended to use. And I'll show them, this is what could happen. So I always say remove the clutter. Easier said than done, but it's a process. Just, meet the person in the middle, I guess, until you can declutter everything. A big place where reoccurrence of falls happen that I've known and I've seen is the kitchen. So someone will be going to the kitchen, grabbing a whole gallon of milk, at the fridge, trying to balance, and then it results into a fall. So I always encourage individuals to get, smaller items that are easily to manipulate. They're easy to hold. They're not very heavy, things like that. Accessibility of the kitchen. So you want to look at where your countertop is. I have a passion hate for over the stove microwaves for elderly individuals, because you have to reach over, and the ergonomics of that is not great. You have to worry about the stove burning, the turning on knobs, falling, and then removing something that's hot out of the microwave. So I always encourage countertop microwaves, just to support the independence of the person, but also make sure that they're safe. If you have cabinets that are high up, just if there are items that are used all the time, bring them to lower, more accessible cabinets, or look at pull-out cabinets. Those are good options for an individual, so they're not supporting and reaching in. I often encourage people, they get, people have standards for their home and I never want to impede that. However, if it's items that you use all the time, I just leave them on the counter. You're not, I always tell them, like, you're not trying to win an award for Martha Stewart. You're trying to be independent and safe in your home as long as possible. And so I find that's helpful for individuals. But I really have to stress that no matter what I recommend, I always worry about the respect of the person. So it always has better outcomes when you work as a team as opposed to telling somebody what they should and should not do. For bedroom planning, you have to make sure it's functional. So as I always start off with asking the person, how do you get in and out of bed? Like, what side do you prefer? What height? I always look at the heights and setting up the room for success. So, and then you can do bed rails also. Sometimes those can be dangerous, but sometimes they can be helpful. It depends on the person. And I know that it's just so person centered, but these are just little things that just to be mindful of. The height of the bed is a big deal because if it's too low, a person struggles to get out of it. And if it's too high, a person struggles to get into it. So you want to make sure that that bed is at a nice height for that person to get in and out. Make sure that they're not going to get stuck in between a wall and the bed, which sounds silly, but I've seen it happen, which was very, very terrible. Accessibility to clothing. So if you look at a person's closet and they have all of their shirts on the very top shelf and they're, trying to hold on to their new walker that they just were recommended, and then they're trying to reach for a shirt, it doesn't set them up for success. So you can always bring them down, lower the items that they use more often, and move like coats and things that they don't need every day to the top. And blinds. You would not even guess the number of broken hips and knees and things like that from elderly people closing blinds.
I would have never thought that.
Yes, and shoulders. So it's always the hips and the shoulders because they're reaching over a couch or they're reaching over the bed or they're crawling in the bed to close these blinds, and it just doesn't support. So it depends on the room, of course, but you want to look at the blinds to make sure they're easy to pull, or you can put it like a string or something to make it easier to manage. So yes, a lot of broken shoulders, a lot of broken hips, closing blinds.
Oh, wow.
Sorry, that was a lot of information. So that's all.
Yeah. Is there something that you see more often than other things? Like when it comes to somebody's bedroom, like what is the most common thing that is a problem in somebody's bedroom that what you would say?
I hate to say it, but it's always clutter. So boxes stacked up, shoe boxes stacked up, just blocking the bed, not enough room for your walker, your wheelchair, whatever you're using to ambulate. So you don't want it to be a maze. You want it to be an open area. And then especially if a lot of people have carpet in their bedrooms. So people don't think about carpet as necessarily being a fall hazard, but it is because it's smushy. The carpet can catch. So things like that. So I always recommend like a low profile carpet or a wood floor, but a lot of people can't afford to just change the whole flooring. So you have to work within your confines. So definitely declutter, but you want to position the bedroom so that the person's able to transfer in and out without anything in the way. And yeah, that's definitely just setting the room up for that person to be able to move around and access everything.
Yeah. Would you say as far as the kitchen goes, that the stove is a big issue, the biggest issue that you see, or is there something else?
Um, the stove isn't a big issue. Typically, I typically take note of the stove with individuals with dementia, which is pretty standard. So if they have memory issues, things like that, the stove does become an issue. But mostly it's microwaves, truly and honestly, because elderly people don't make big meal typically, and I don't mean to categorize all elderly people, but in my experience, they typically make a meal for themselves and they don't use the stove often, maybe for tea or warm up a can of soup, something like that. So it's really the accessibility to the microwave, because I find that that's the choice that a lot of older people who aren't feeding a whole family anymore make. So
Right. So they're trying to reach, or they, I've seen too, or sometimes they put something in for too long and then they go in to reach for it without like a hot pad or something like that. And then, you have oatmeal spilling and you're burning yourself. And so I can understand that, how that would be scary.
yeah. And then for the oven too, I guess I have had experiences where an individual is trying to take something out that was way too heavy, and that can be unsafe. So just being mindful of the structure of whatever you put in and the weight of it when you're taking it out, because it's easier to put in than it is to remove when it's super hot. So
Yeah.
just because you can do it when it's cold doesn't necessarily mean that it's easy to remove when it's 475 degrees.
Right.
I have a couple questions for you on the, we had this situation with a friend of mine, his mom is in, mid-80s. And they have these super high beds. So the, family bought her a step with a railing on it. What do you think of those?
I guess it depends, because why was she attached to the bed? Could she not afford to get a lower bed? Was the bed frame wasn't able to be modified to be lower? Or I guess what was the choice that went behind them getting a step with a rail? Because typically that's not my favorite recommendation.
Okay.
I will say get a new bed frame, or I know a lot of people don't like this, but you can always take how the mattress is on top of the, I can't think of the name of it.
Back spring.
The box spring. Sometimes I'll just say like pull the box spring, because that'll give you like 6 or 7 inches down, although it makes the bed not as comfortable, but
Yeah, we
I'm not a big
tried all
fan
that. She wasn't going for it.
No.
She had nowhere to put the box spring. So we weren't gonna pull it out. So, all right, that's helpful though.
Yeah, or if you do have to do a step up, I would really encourage to get like a walker size step, almost something larger where your foot's going to be planted very solidly, and you can even put 2 feet next to each other, so you can do a step up, meet your feet, and then be able to have enough radius to turn and sit down in the bed while holding the rail. So it's all about positioning too at that point. So you want to set yourself up for success and make sure you practice, because a lot of what OT is too, that people don't realize, is building up habits and routines. So I can go into a person's house and be like, this is how you're going to use this step up and this rail. But until you practice it and it becomes almost like you're not thinking about it, it's a concern. Like, so any change in daily routine and habits also increase the risk of falls, because you're now thinking extra about things you're doing. So
that's a great tips. Thank you for that.
I have one last question on this, and I know we talked a little bit about blinds. Can you tell me what some of your recommendations are for those people who have blinds and that are injuring themselves because of it? What are some of the things that you do to steer away from that?
Well, sometimes I'm just like, do you need to close them and open them? And no, but for real, so if they should be able to access the blinds to open and close them. So I always encourage, if it's something that you're going to be opening and closing often, please do not put a couch in front of them. Blinds are expensive. So what I also recommend, some people don't like, but are just the pull curtains. So you can pull it shut and you can attach like a rope or something, so that rope just pulls it across, and then just keep the blinds up. So that way, day to day, you can open and close. And then if it's like to keep heat out or keep cool out, you can use the blinds, but just not as often. So that reduces the risk of falls. But definitely just don't block it, because that's what happens, is that a lot of people put a couch in front of their main window in their living room, and they're reaching over that couch. So or just honestly, if we can't set up the environment for the person to be successful, and you really need something, I always encourage people to have a support system. So if you have these blinds that you need to dust or that you cannot close, call somebody, because I guarantee you someone's going to want to help you. And if not, then set the environment up for success. But sorry, let me take a deep breath. Another thing I want to add too is that the individual that's making these choices to climb over something or do something that they could do, 20 years ago, but maybe is not as a safe choice now, is to just think about it first, because a lot of people just do it out of habit, and that's when falls happen. So think about, where's my body at, what is around me, and where am I reaching to? So that's really a big part of it that people underestimate. So
Yeah. Well, as we're talking about falls, I changed our slide over to the fall, and I know you were just saying about the fear of falling increases the risk.
yeah.
So, can you tell me a little bit about what you've experienced with that?
Yes. So when individuals have a fall, and let's say it does result in something like a broken hip or a broken shoulder, it's very traumatic for that person, not only because they had to probably get picked up by EMS, they probably had to go to the hospital, they had to have surgery, and then the pain levels that they're experiencing are out of this world. And unfortunately, pain management is a challenge for a lot of physicians to work with a client. And so you remember that pain, and you remember, oh, if I fall again, all of these things are going to happen. And what happens is an individual will tense up, or they will make impulsive decisions about walking or moving around or navigating. And that increases your risk of falling, because you're thinking in your head the whole time, don't fall, don't fall, don't fall, don't fall. And by doing that, you're looking down, you're not looking up. And that increases your risk of falling. You need to be up and looking around, just kind of like riding a bike, right? Like when you were a kid, they told you don't look down. If you look down, your bike's going to go down. Look ahead and you'll stay up. It's the same concept, in my opinion. So
Yeah, I think with driving or anything like that too, you should be looking at your surrounding areas, not just right in front of you on the road or right in front of you on the trail you're walking on or something like that. You have to be aware of what's around you.
absolutely. I'm just scanning. So
Yeah.
yeah, fear of falling increases falls, unfortunately.
Yeah. What about shoes?
Shoes. So a lot of people will say you need to wear tennis shoes with good support in the house to reduce your risk of falls. I am kind of on I work with the person. So some people, if they feel more comfortable, or if they have neuropathy or something like that, where they need to have the sensation on their actual bottom of their feet, I try to meet them where they're at and just make them more mindful of their placement, slip hazards, things like that. Because if you're, well, first off, let me start off. I don't like socks. You don't walk around in socks. Um, Nothing good ever comes of that unless they're sticky on the bottom. I really don't walk around my house in socks. So it's either barefoot, sticky bottoms, or shoes, in my opinion. So I don't know if that's helpful, but yes, you're just on carpet, even socks are slippery, especially on stairs. So
Yeah, I myself have fallen with socks on, so I totally get that.
yes.
What about slippers? How do you feel about slippers?
Slippers, I do not like the kind that you just slip your foot in and do not have a back. If you want to wear slippers, I would encourage you to wear a full shoe slipper with a good sole. They're so comfy, but they provide that support, and they aren't slipping or flopping off of your feet, and increasing your risk of taking a misstep. So like with the slippers that don't have a back, if you're walking and then your slipper walks a little bit more than your foot does, you're stuttering, or you're kind of trying to get in there. So definitely a full slipper shoe with a nice sole.
Yeah, that makes sense. Now I see on here wall walking. What is wall walking?
So when I think of wall walking, I remember this one client I had. He's an elderly gentleman. He is like, I don't need a walker. I just hold on to the walls. And he had his steps planned out in his house to a T.
He labeled it.
He did for me, wall walking. So a lot of people, this, they were, so let me, a lot of elderly people, before they have a fall, were already having a hard time getting around before that fall happened. And by maintaining as much independence as they can, they typically will use their surroundings like humans do. So they'll grab onto tables, or they'll have like a hutch placed over here where they know they can grab that to support themselves on this one open area. You know, humans are smart, and individuals are smart. However, wall walking typically leads to falls as well. So if you're relying on that hutch to be there and it's not there, or it moves, you're going down with it. So that's what I mean by wall walking. And that is an uphill battle. It's an uphill battle with a lot of people because it's a routine and it's a habit. So again, meet them halfway. It's a process. It's not an overnight thing that will happen.
Yeah, I feel like that can be unsafe too, because if you are going to fall, what are you falling into at that point? You know, if you're relying on, like you said, a hutch or a wall or something, you know, I just picture somebody hitting their head or hurting themselves really badly by relying on something that is a hard surface.
Yes. Yeah. And not only that, but a lot of times the person is looking for the next thing for them to get to, as opposed to just walking down the hallway. So it's almost like my kids play lava, you know, the floor is lava. And that's kind of how I think about it, is that you're not necessarily focused on your balance. You're focused on where's my next point where I can grab onto, which also increases risk of falls.
Right. Yeah, you're just thinking about your next things. You're not focusing on what you're doing.
Yes.
So stairs, I know stairs are a really big issue, and especially like when I go and open cases with clients, one of the biggest things that we talk about is stairs. How are you going to get to that bathroom that you insist on using? Or, you know, a lot of times falls have occurred on their stairs. And I'm surprised how many people don't have stair lifts or, you know, another option. Tell me about what you see with
The stairs.
stairs.
So unfortunately, stair lifts are like $15,000. They're quite expensive, and a lot of people have their full bathrooms. If they're in a you know, 2-story home, a lot of the full bathrooms with the full showers are upstairs.
Yeah,
If they're physically able to do them, so they have the strength to do them, I always encourage to have bilateral handrails. That's not an expensive modification to make to a home. So they have 2 points to grab onto. Although sometimes, you know, the stairs are too wide for the span, but at least you have one side going up and one side going down. I also encourage, you know, you'll hear PTs drive this home, but the walking. So up with the good, meet. Up with the good side or your stronger side and meet. Up and then down with the bad, and then meet down with the bad. Because when a lot of people want to lead going down with their bad foot. And the reason that that's not recommended is because when you think about doing the stairs, when you're going down, where is all of your weight shifted to when your foot is going down? It's on the leg that's it's hard to explain, but it's on the leg that's supporting you. So you want to go down with your bad foot because that bending is happening in your good foot. I did I explain that right? Or like, well
yeah,
enough, I guess.
yeah. No, that makes sense to me. It's just different of how people think about it. You know, when they're trying to go down the stairs. So that makes sense. You know, it's a good thing to explain to people.
Yeah, think about where your weight is shifting to. So if you're
Right.
shifting forward, sure, you're landing on the bad side or the weaker side, but you're holding with the stronger side while you're going down. And so when you meet your weaker side, that gives you a better base of support. And then again, no socks on stairs. I don't wear socks on stairs ever, and my kids don't.
Right.
Nobody. And if push comes to shove, I always tell people you can go down on your bottom, right? Like you can go down on your bottom. It's harder to get up, but you know, get up the stairs like that. But if you're afraid of falling down the stairs, there's nothing wrong with, if you're able to go down on your bottom, if as long as you can get up at the bottom.
Right.
Yeah.
So
Yeah, we actually had a client in the past who had dementia who for whatever reason was focused on the staircase, you know, all the time. That's where she went. That was where she wanted to be, was the staircase. And we had such a hard time convincing her significant other to block that off somehow, or, you know, create a distraction from that. And she ended up falling down the stairs. And so, it's such a dangerous area for not just elderly people, but people with dementia or people with, an injury of some sort. And they still feel like they have to go down and do their laundry. I had a lady once that basically dragged her laundry up the stairs because she would insist on continuing to do that. And it's just amazing what people will do to keep their routine.
Yeah, well, and it's because it's hard to give up independence. Fortunately,
Yeah.
I haven't been there at that point, but that's why I try to be, or I am empathetic to people, and I definitely think that's what makes me an effective OT is because we listen, we work together, and so we didn't even touch on basement stairs and laundry, but I always tell people throw the basket down and don't carry it, just throw it down and then there's pulley systems that are very cheap that you can put up, like because a lot of basement stairs are straight. So you can put a pulley system and then put your load up, at the bottom and then walk up the stairs safely and then just you can pull it up when you're up there. My mother does that. She has MS, so it works for her.
I've never actually seen that. So thank you for mentioning it.
Yeah, it's I mean you have to do smaller loads, but no one's telling you that you have to do 15 loads of laundry that day, You can go at your own pace in your own time.
Yeah, absolutely. So let's talk about transfers a little bit. What do you mean by planning your transfer?
So before I transfer anybody ever, I look at where they're starting, where we're going to end, and the in between. So you want to make sure that the person is in a position where, so when we're talking about a transfer too, I'm assuming that they're not able to do it themselves. So they're going to need some assistance. Is that kind of where we're talking about, like if a caregiver were to be there or if like a family member were there to help, or even, I guess even the
Yeah.
person, you can set yourself up to, okay, so I'll do it two different ways. I'll do it individuals and then I'll do with a caregiver. So if you're a caregiver giving a person or taking care of a person, and let's say they need 25 to 50% help getting someplace, so let's say from the bed to their wheelchair, what I'll do is I'll make sure the path is clear. I'll make sure the bed rail's down if they have a bed rail. I'll make sure the bed's at a good height if it's a hospital bed. If it's not, you just have to work within your confines. And then I'll make sure that where I'm transferring them to, we both know where it's at. And then I'll even talk with the person. I'll be like, you know what, you can put your hands here, you can put your hands here. And this is where you want to reach to when you want to finish. So I want your right hand to go to this side of the wheelchair. And so we'll talk it out in our brains before we even do it. And I find that that's so incredibly helpful to reduce risk of falls. And it builds up good habits. For an individual that's doing it without a caregiver or without assistance, they want to make sure that their wheelchair or wherever they're transferring to is near them. And they want to be able to reach it and place it. So they want to also set themselves up for success, have everything positioned before you move.
Good plan. Misty, did you have anything you wanted to talk about on this particular slide?
One thing is, I ran into recently is one of our clients is 98 years old in a community, and she was walking with her walker and fell over the front of the walker. So she ended up with a black eye and, injury to her hands, however she went down. So the community, just kind of picked her up and, didn't really do an analysis so much to try and figure out what was occurring. So, one thing was the carpet had pulled, how the ridge that takes it from carpet to tile had actually pulled out.
The transitions, yes.
Yeah, and so I think she had difficulty getting over that. But the other thing that I looked at when I looked at her walker was the wheels on the walker were flat. And we see that all the time, but they don't normally have an issue. I haven't really had one where they couldn't get over a threshold, but she was having, when I went back the following week, she was having problems with that walker getting over thresholds. So is there a point on a walker where you're looking at it going, okay, we got to get new wheels on this, or we need a new walker?
Well, Medicare says you only need a walker every 5 years or something like that. But the wheels are interchangeable on walkers. So you are able to just click them, pop them off and put them back on. And you can even order them on, not to like plug Amazon or anything, but they're all over the place. They're typically one size fits all. And yes, I'll look at the joints of the walker because a lot of people, close them and open them, close them and open them, and that
Sure.
makes that loose. And then so I always look at the joints of the walker to make sure they're nice and sturdy. And then I also look at the wheels to make sure that they have traction and they're not like they're not square, so absolutely. Yeah, and you can even go to any durable medical equipment company. There's Benson's, Quality Home Medical, there's so many, and just say, hey, I have this walker. Can you refurbish it up for me a little bit? And I guarantee you someone will be happy to assist you.
So they can also fix that issue with the wiggling of it as well.
That's more of a new walker situation. You need a new frame
Okay.
for that, but the wheels
Got
are very much interchangeable. And even the sleds. So let's say you have a two-wheeled walker where there's two wheels in the front and then no wheels in the back. You can get different sleds on there. You can put tennis balls on. The feet are very easy to modify on all those.
Right. Is there one, and I know we went a little bit ahead, Krista, I'm sorry, but is there is it better to use the tennis balls or the slides or because she ended up getting a new walker, but had the rubber bottom on them and it was like, and I'm like, okay, well, she can't use this. It's like, it's catching a little on the floors, so I did end up putting the tennis balls on there, but what's your thoughts on the differences there?
So a walker like that is meant to be like pushed, stop, push, stop. And so I think that we as a therapy or whomever, we always try to because not everybody walks like that, right? A lot of people, it's more of a fluid motion, but they're not
Yeah.
necessarily ready for a four-wheeled walker. That's not safe. So I like the sleds. I think it's a perfect personal preference for the person. Tennis balls wear out really fast and you have to cut them. And typically people need help putting those on because you've put them on, I'm sure, Misty, but they're
Yeah.
challenging to pop on there. The sleds are pretty inexpensive. You can get them on Amazon. They're just like little white pieces of plastic that literally look just like sleds or skis. And they just attach right to the bottom. You pull the plastic off, you pop those on, and they don't scratch the floor. I've heard too bad. So, but you could always put like a moleskin on the bottom of them too to make them if you have the moleskin would be good for like wood floors or tile, but probably a normal sled without a bottom would be good for carpet. So,
Okay. Got it.
yeah.
Thank you.
Yeah, I'm so glad you guys brought up walkers because I know we're going to talk a little bit about medical equipment, and I feel like it's really important because there is so much out there and so many different things. And people often question what does what and what does this mean? And
Or they use equipment
what
wrong that's supposed to be supporting them, and then it results in a fall.
Yes, exactly. So I'd like to talk a little bit about DME and Caitlin, what you know about the differences. And I know this is one of your things that you talk about a lot. So go ahead, please tell us.
Um, so let's say you have someone that you care about or an elderly person that falls, and then they get back from the hospital and they're going to skilled nursing, and then you get this list of things that are recommended when they come home. Like they were walking independently before, but now they aren't able to. It can be overwhelming. So the most probably intense thing, I guess, for durable medical equipment that would be put in the home is probably a Hoyer. So a Hoyer lift is for somebody who is completely dependent for transfers or, max to dependent for transfers. So it's something that when you're laying in a bed, you can roll the individual side to side and it has a sling that you put under them. And then there's a machine, like almost like a claw that comes down and you can adjust it and you hook the sling onto the Hoyer. And then it's a crank or for the older ones, or a lot of them are electric now where you hit the button and the person will be lifted in that sling and suspended in the air. So Hoyers are very safe, in my opinion, as long as you are trained properly on how to do them and you're talking to the person the whole time. because it's not a comfortable feeling to be feeling like you're suspended in air and you're totally reliant on that person that's working with you. So Hoyers I've seen recommended after somebody had a severe stroke, after they've had a spinal cord injury, after a brain injury, things like that. So they can be a little intimidating, but definitely ask for, and now again, any discharge process, you can ask for training and make that a priority because you're important and that person that you're going to be caring for or assisting is just as important and they deserve the time that it takes.
Yeah,
Um,
absolutely. We have caregivers that come in that if they are going on a client that requires a Hoyer lift, we've actually put the caregiver in the Hoyer lift and had another caregiver lift them up and see how it feels because we want them to have that empathy when they go in. Like, this is not a great feeling, and it can be very scary. So we find that when we do that with our caregivers and put them in that situation, they're way better in the home explaining to the
Good.
client what is happening. And they will even tell them, I've been in this, I know how it feels,
That's
and it
awesome.
really helps.
Yeah, because the individual's so vulnerable. Like not only that, but sometimes your bottom's hanging out or, different slings
Yeah.
and then they lap around your legs. And it definitely helps the person because they're at home and that it gives them more ability to move in and out. But that's fantastic. I wish more places did stuff like that because sometimes there's a disconnect there between just a job and then that you're dealing with actually a person. So
Yes.
very cool. One thing that I didn't send to you that I just thought of that kind of goes with the Hoyer is a Sarah lift or a sit to stand. And
Mhm.
so that's a modified Hoyer. You have to be able to have core strength to be able to utilize it, and you have to be able to have your legs strapped in at the bottom. So your legs are strapped in, and then you have a sling that goes around your back, and then you take your hands and you hold on to 2 bars or whatever is offered, and then the machine actually puts the person into a standing position. You verbally communicate with them like, I'm going to unlock the Sarah lift, we're going to pull back, and then you can rotate them while they're standing, and then they can seat them back down or sit them back down. So that's a hybrid between a Hoyer and just like a stand pivot transfer to give that person that just needs a little oomph but still has some core strength, the ability to transfer without being completely suspended in air. So that's another option too a lot of people don't know about.
Yeah, thank you.
Do you guys work with Sarah lifts a lot or to stands?
Yeah, we have one client currently that uses it. So we are somewhat familiar with that.
I find them to be underused and typically a preference of clients when I do trial them. So they're like, oh, well, I didn't know this was an option. I'm like, yeah, probably sure.
Well, you don't typically see people being approved though out of like a skilled nursing facility being able to get one of those, do you?
Well, I don't know if it's the chicken or the egg. So I don't know if it's that it's approved or maybe people just aren't recommending them. So
Mhm.
I don't know which one it is, but I can say I probably didn't recommend them enough when I was at the skilled nursing facility. Looking back, I probably would have recommended more sit to stands than I did over Hoyers. So I think it's just an education as you learn and as you know your resources. Because
Mhm.
I'd have to look to see if Medicare covers that though. I'm not entirely certain, but I would assume so in some capacity.
Right.
Was that your question? Sorry.
Yes. Hmm. You don't know unless you ask.
Right. So I know you and I talk about transport chairs, Caitlin. Tell me, what's the difference?
So a lot of people will be like, "We got this great chair for my mom, and it's so lightweight and it's awesome." And I'm like, "Is it a transport chair?" And they're like, "Yes." I'm like, "Okay, well that's great because you can use it with them, but your mom can't use it independently because she will fall." So a transport chair does not, it has 4 little wheels on the bottom. It has a different base of support for gravity that you cannot self-propel it. No, do not foot walk with it. You need someone to be pushing you with a transport chair. They're lightweight, they're great if you have somebody with you. A standard wheelchair is heavier. They're like 45 to 65 pounds, but they're utilized, they have a different center of gravity base of support, and you can self-propel with those, and you can foot walk with those without tipping over. So transport chairs get into doors better, they get into the community better, but not independently. So that's my my soapbox about transport chairs, because a lot of people just don't know. They see a lighter weight thing and then it results in a fall. So
We see that come up a lot. A lot of people think that, it's a wheelchair and they're in a transport chair, and we have that same conversation. You're going to fall and hurt yourself. We have to have
tip
somebody
right
else.
forward.
Yes, and I've seen that happen. So the more we can talk about that, the better.
Yes. Yeah. So different types of chairs. And so I guess, and we can put pictures up too, but yeah.
The question I have on that, similar but different, is rollators. So instead of the walker, the lightweight walker, a rollator, and the safety of a rollator versus a regular walker.
Yeah, so that's where we get into the two-wheeled walkers, functional transfers, and four-wheeled walkers or rollators. So a two-wheeled walker is beneficial for a person who has poor balance. They're not able to control something as easily as a four-wheeled walker. And it's easier for for transfers that are harder. So if a person has a harder time getting up out of a chair and walking, I would encourage them to use a two-wheeled walker instead of a four-wheeled walker. If a person has a hard time with judgment of speed or distance or reflexes for brakes, I recommend a two-wheeled walker over a four-wheeled walker. I recommend four-wheeled walkers for individuals who have COPD, who have a hard time getting from point A to point B, but can maintain a good, fair plus balance. They can stop, so they can use the brakes with both hands, and they have good judgment. Because a four-wheeled walker really is utilized for energy conservation, in my opinion. And people might disagree with me, which is okay, but you're not going to get, I never want to see a person bearing down on a four-wheeled walker while they're walking, or a rollator while they're walking. Those are utilized to give you some support, not a lot, and they're meant to be locked, and you can sit and take a break while you catch your breath, or while you take a minute to take a break.
Right.
So that was a big thing too. A lot of people want the rollators and the four-wheeled walkers after they break their hip. And I'm just like, Susan, you can't use a four-wheeled walker because you're bearing down way too much on this walker right now. It's just not appropriate. You'll flip it, you'll crack it, it'll shoot out right from underneath you. So
Yeah.
Go
Go ahead.
Kristen. I was just going to say, we had a recent situation where the thresholds between the carpet again and the flooring, a regular walker, the lady was somewhat unsteady, and she would pick it up and put it on the carpet, she'd be like, no, I'd be like, no. I mean, one time someone told me never to use the rollator, but in this situation, I had recommended the rollator because it did go, we had a carpet company come out and make it as flat as we could, just flatten that threshold over, but it was still, the regular walker would not work. So that situation, she did much better with the rollator.
what was her, what would you say her balance was like? Like if she was standing with her eyes closed, were you able to tap her and she'd be able to correct her reflexes?
You know what? I had never done that, but that's a really good question.
Yeah. So that's really, I wouldn't say never use a rollator for that, but I always would think about their balance first. Because but it sounds like her balance was fine if she was taking her other walker and physically getting it up and moving. So I think a rollator would be appropriate. And it sounds like it was an easier transition for her. But I always tell people too, I say, make the DME work for you. Don't work for the DME. So if it's if you're picking it up and moving it, it's just a nuisance at that point for you. So then maybe we need to reassess like you did and see if something different is a better option. And it sounds like the rollator was. So no, I'm not against rollators by any means. It's just, there's different ways. Just like after someone burst breaks their hip, you actually need a standard walker. So a lot of people get two-wheeled walkers that where they have like the wheels on the back, but you're really supposed to be like planting, walking, planting, walking. So that's when a standard walker is good too. So just it's so variable.
Yeah,
You've
I
got
will
the
tell you-
walkers with, I'm sorry, walkers without wheels, walkers with front wheels, and then a rollator with all four.
And brakes and a seat.
And brakes. Yes, and a seat. Okay.
Yeah, I will tell you, Caitlin, my grandma had knee surgery and she was recovering from the knee surgery and she was using a rollator even though it was not recommended. And during that time, she was like bearing down on the rollator. So she was completely bent over and she did that for so long that when she had to have her hip replaced, they actually had to cut some tendons so that she could actually stand straight up again. So an
Wow.
example of the rollator.
Yeah,
not being
they'll like
good.
lean and like I've seen some wild things where they're like their whole body's at it and they're just like
Yes,
gliding along, but bent over.
that's
Well,
exactly what she was doing. That is exactly what she was doing. And all of us were saying, you have to stand up straight. You have to stand up straight. Well, it got to the point where she could no longer stand up straight, even if she tried, and she lives on her own. And so there's lots of hours of the day where somebody is not there and she's doing what she wants to do anyway. So,
it's habit and routine.
yes.
It's like I always tell people too, especially if you're not in a wheelchair and then you are recommended to be in a wheelchair so you can be safe and independent. A lot of people will start getting smaller and smaller and smaller and smaller. And I'm always very much encouraging people like big movements. If you don't use it, you lose it. Frozen shoulders, all those things. So yes,
Yeah.
it sounds horrible to have that your grandma had to have her tendons cut. Like that's the worst case scenario, essentially, right?
Yes. Yeah, absolutely. But she is up straight now and she's learned her lesson. So I guess that's what it takes sometimes, right? You have to learn the hard way. I don't know.
Have to learn the hard way.
Yeah.
Oh, here, sorry. A client's called me like 15 times. Let me just let them know.
Yeah. So I'm talking about, I see canes on here and I just want to know from you, what situation is a cane acceptable and what type of cane? Because I will tell you, we have a client that prefers to use a cane. And it's a quad cane. Well, actually he has both. He has a single point and a quad cane. He wants to use a single point most often. And he is, in my opinion, somebody who needs a walker at all times. The cane doesn't seem to provide him much support. So can you tell me what that looks like for who is a cane acceptable?
Again, I assess their balance. So, and I forgot to send you to like a Hemi walker, which we can touch base too, but it's like a hybrid between a walker and a cane, and it's used for individuals who have had stroke or have hemiparesis. So one side's weaker than the other, where they only have one hand to hold. So it's like a big base platform and then it kind of tees up. So, I see those a lot after strokes, things like that, because it gives a wide base of support, but it really just depends on if there's one-sided weakness, if there's bilateral sided weakness, and what that person's balance is. Because what you're trying to do with a cane is you're trying to make a tripod. So you're trying to make the largest base of support for gravity or to resist gravity. So a lot of people like quad canes because it gives a bigger, wider base of support to push down on. I'm not a fan just because I've seen so many people catch them on stuff and trip on them. Especially if they have the teeth that poke out facing them as opposed to facing outwards. Because I don't know if you've seen a quad cane, like there's two straight and then there's like two claws, and the two straight should be towards you and the claws should be facing out. So if you have the claws towards you, you get caught up in your feet. A single point cane, I guess it really just has to do with your balance. So if you have like a fair plus balance, or I'm sorry, fair minus balance. It's Krista, I'm sorry. It's so hard to say because it's so situational on the person. I
Yeah.
would have to have eyes on them and um, do an assessment. But quad canes, they have a bigger base of support. A single point cane, it's just for somebody who needs that little extra oomph for their to make a tripod for them, the base of support to just keep them like. And then a hurricane is a cane that's essentially a single point cane, but it has a wider base and it stands up on its own. So if you take your hand off of it, it'll stay upright for you, almost like a quad cane. So a lot of people like those a lot because they reduce the fall risk, but they also stand up on their own if they let go.
Yeah,
I
I've
know.
seen commercials for those.
Oh yeah. Oh no, I'm doing a commercial for them, but I do like them. I have a lot of people that like them.
Yeah.
So really it's like three things. You want to assess the person's balance. You want to talk to them about their preferences because if you give them a walker and they don't want to use the walker, they're not going to use the walker. So, and then it's kind of then you look at what would suit them best.
Okay. Thank you for that. Yeah, this particular client definitely doesn't want to, he says he doesn't want to go backwards. So to him, the walker is going backwards, right? But unfortunately, he, without anything, if he was to try and stand up on his own and stay standing, like balancing, he wouldn't be able to. So there's a lot of deficit there as far as weakness, in several different areas. But we'll just keep trying to push forward with him in the walker.
Yeah. I was gonna say we could talk like if the rollator too, like do you think he'd be if he could be appropriate for that? Because that's not necessary. You could kind of pitch that like, oh look, it's a seat for you to sit down too. And it's better now.
No, he has a rollator. It's not happening, but it's just always good to get more information, to be able to say to him. So
Well, I guess I would go with your gut. If you don't
yeah,
think it's safe and he doesn't look safe with it, it's probably not safe. And then I would just talk about what could happen. And then you really will be set back.
yeah, absolutely. So I was in a home last week that the woman had just gotten home from rehab and they were trying to somewhat modify her home so that she could live on her own. And they had grab bars in the bathroom, but they were suction cup grab bars. Can you tell me how you feel about those and what do you recommend in those situations?
I am not a fan of suction cup grab bars by any means. And I know they'll pitch on like, oh, well, this seal will be green if it's good and it's red if it's broken and blah, blah, blah. But how often before you step into a shower are you going to examine to see if the seal is green or red to be broken? Probably never. So they're just unreliable. They're unreliable. So if you need to have a grab bar, it's not that, it's really not too expensive. A lot of bathrooms can be very easily modified to put them into a stud. And you can get one or two, but no, throw the suction cups away. It's too unpredictable. It takes one time to have a horrible fall. One time. So why risk it?
Right.
And I feel like a lot of the falls in the bathroom are some of the worst.
Oh, absolutely. I was telling Krista too about the glass shower doors. Those are a nightmare and a half because a lot of people like them because they keep the water out and they're like, well, then I won't get out and I won't be slippery. But glass doors, it limits your ability to get in and out of the threshold. It limits the ability for you to step in and out, for you to grab and maneuver, for somebody to even access you if you did fall or to access you if you need assistance. So I always tell people like rip those bad boys down and put up a curtain because you can take a towel and wipe up the floor. There's so many other things you can do to modify the water, but I do not like glass doors on showers. I feel very passionately about that. So someone got stuck. I had a person fall in one and the glass door shattered on them.
Oh my
I mean,
gosh.
it was safety glass, but still like when you're naked and cold and you have safety glass all over you, it's horrible. Horrible. So
Yeah. Take that hazard right out of there.
yeah, and they're easy. Like I've done it, I've removed several. So they're easy to do. Really, you just, take off the framing and peel off the caulk and put up a shower curtain. 10 minutes.
Everybody take your glass doors off your showers.
That's right.
Even for toddlers, like get them off. So
Yeah. Do you want to touch a little bit on ramps and medical beds? I know you want to talk about those.
oh, well, I can really quick too about the bathrooms, like just removable shower heads. And then a lot of people don't realize that they have like the start stop water sprays. They don't know what those buttons are for, but that's to start the water and to stop the water. So it reduces the splashing and water everywhere. So I wanted to add that too with the showers.
Thank
They're
you.
easy, fairly inexpensive and easy to replace your shower head. So they make a world of difference. So mini ramps and large ramps, and I can provide some resources too. I just have to get those together. But mini ramps are good for, they're like, you can just get them on, you can order them online or something like that. But they just match up to, like, if you have a sliding door where you have like that 1-inch gap or threshold. So many people trip on those or can't get walkers over them, things like that. So, I mean, it definitely depends on the household and the situation, but I always recommend getting a little mini ramp to get in and out of sliding doors, especially if you are using a walker or a rollator or something like that. Not necessarily, no, don't do it with a cane, of course, because then you can just step over it. It's assuming you're appropriate to step over with a cane, but it makes it just a transition so much easier. I think they're like $40. I had a gentleman who had a bathroom that he loved his threshold. It was this beautiful marble threshold, but that bad boy was like 1.3 inches thick. And it was not coming out of his house. He loved it. And I said, you know what? We will keep it for you and we will make it work. So I ordered him a little mini ramp off of online and worked perfectly in and out. He was just fine. So
Great.
yes. And then large ramps, those can be expensive. I price those out a lot for my clients because a lot of them are wheelchair bound. They use that as their main mobility. And ramps can cost anywhere from $5,000 to I've seen as much as $20,000. So
Wow.
there's resources in the community. I like aluminum ramps, they're weather resistant. A lot of them are anti-slip. You have to use specific salt on them for the winter, but wood ramps are okay. They work. They have a lot of maintenance to them. And then you always should follow the ADA standards of 1 inch for every 12 inches out. So for every inch you're going up, you need like a 12-inch clearance, I think, if I'm remembering correctly. Something like that. I can look at my stuff.
Yeah, I know the spacing and measurements on those things are super important because if they're not right, then you have more of a risk of falling.
Mm-hmm. Yeah. So you want to make sure that the incline is appropriate, and it's like for every inch you need 12 inches out. So they can be quite long and you have to kind of wrap them around if you have a really high threshold. So
Yeah.
but there's definitely resources in your community that people don't know about that can help get ramps. Even Home Depot does some free ramps for people. So it's just about asking.
Wow. I didn't know that. Missy, you have anything you want to talk about on here?
No, not, we're good.
Okay, so thank you so much, Caitlin, for going over all of this information with us today. It was a lot of information and I know you have so much more. But if you are looking for an OT or looking for recommendations, Caitlin is awesome. And I have put her information up here on the screen so you can contact her by phone, even if it's just trying to find, some help in the community. She is more than willing to do that. So Caitlin, thank you so much for joining us.
Thank you so much for having me. This was really fun. I was nervous, but I'm glad that you're doing this for the community because it's not a lot of people have access to this. So I really I'm really appreciative that you're doing this.
Yeah, thank you. And Caitlin works with us on a client that we have that, we do home care and she does the case management and OT for her. So, we do home care. We can help with anybody in the field who has been in, in an accident or has some kind of disability. We can help with their activities of daily living and help you remain independent. So you can give us a call or you can give Caitlin a call. And we thank you so much for joining us.
Thank you.
Bye.
Bye.